Well, good morning, everyone. I'm Rebecca Richards-Cordum. I'm chair of the bioengineering department at Rice University. And on behalf of my colleagues in the Beyond Traditional Borders program and the Baker Institute for Public Policy, I'm really delighted to welcome you to our first annual Global Health Design Challenge Symposium. It's an honor that the president of Rice University, David Lebron, could be with us this morning to welcome you and share his thoughts about Rice's expanding future in the area of global health. David.
Morning. My chief job is to get everybody back on time, which means I need to end in 30 seconds. It's actually a great honor for me to be here. I want to thank all of you for joining us for this very important endeavor. I especially want to thank Rebecca Richards-Cordum for her leadership in moving Rice forcefully into this arena to address the problems of global health. These are, of course, problems that no one person, no one institution, no one country, no one discipline can possibly solve. What heartens me as, I guess, a fallen lawyer in some respects, with the renewed interest in global health, is the accepting of responsibility. One of the areas that I worked on as a lawyer was human rights. The fundamental premise underlying human rights is that they are universal and that we all have a responsibility, regardless of where people are being persecuted, to see that they are not, to see that they have the chance to lead better lives. Unfortunately, as we look around the world, we see lots of opportunities to improve people's lives. But those lives, even with freedoms, are not going to mean a great deal if people don't have health, if we don't find ways to solve the problems that afflict people's health around the world, and I think one has to say, most especially in Africa. There, of course, is an element of self-interest here, and that eventually the problems of global health, of diseases like AIDS and others that affect people far away, come home to roost. And so we have not only an obligation, but I think a very strong interest. The other thing that I think is very exciting about this initiative is not only does it bring us in closer collaboration with our partners at the Texas Medical Center, but it also requires that we bring together in this common endeavor disciplines virtually across the university as well as across the medical center. This conference today and tomorrow is about integrated technology solutions to advance global health. We do need better technology, but it's not simply better technology. We know in this country, perhaps better than most places, how to invent new technologies, how to find new ways to solve health problems. In fact, I would venture to say that no country is as good as the United States in finding monstrously expensive ways to solve health problems. If that's what we do, that will be of little benefit to the developing world where the health problems are most acute. If we solve health problems only with reference to our own culture and our own economics, those solutions will not be of benefit to the people in that part of the world. So it's very fitting that this conference should be held in the Baker Institute, an institute of public policy that seeks to bring together people of all disciplines, of not just science, which is essential, and technology and engineering, which are essential, but of history and politics and culture. We need to understand all of those, as well as the economic realities of the developing world, if we are to deliver or actually if we are to be able to participate in delivering effective health solutions for their problems. So it's especially fitting that universities, which have the capability of bringing together all of those disciplines, of understanding how things work in countries around the world, of what the daily realities of people's lives are, because it's in the context of those realities that healthcare will be delivered. I heard Rebecca talk the other day about people having to walk miles and miles in Africa just to get to a clinic, and how one could not possibly deliver an effective solution to healthcare if it required multiple visits to a clinic. Those are the kinds of realities that we need to take into account, and universities are especially suited to do that. Here at Rice, we've launched a number of initiatives. As you've read and heard, we're very proud of our bioengineering department, which is a top 10 bioengineering department, and we have little doubt under Rebecca's leadership that it will be top 5. We're very proud of the relationships that we have developed and continue to develop with the Texas Medical Center. And we look forward with great excitement to the construction of the Collaborative Research Center at University in Maine, which will bring together 5, 6, or perhaps even 7 different institutions from around the medical center, and perhaps even an institution from Mexico, as we look forward to solving some of these problems together, recognizing again that no one of us has the solutions to those problems. Part of the vision for the second century that we have elaborated emphasizes the international dimension of Rice University. That is, of course, an opportunity for us to both learn from the rest of the world and to contribute to the rest of the world. And I'm very pleased to see here today a number of students who I think both have a lot to learn about that world, and we are very fortunate, have much to contribute. So I want to thank again all of you for coming, for taking your time, for working in this common endeavor as we seek to find the best technologies that can be used to make a real contribution to improving health, not just here at home, but around the world. Thank you very much.
Thank you, David. We're here today to talk about how we can develop new technologies. And as part of this conversation, we've tried to bring together students and experts in global health from Rice, from the Texas Medical Center, and from around the world. And I think it's a special opportunity to think about what we as academic institutions to address these very important needs. Many of you in this room are well aware of the enormity of the global health challenges. But I think one of the things that academic institutions can do is to play a special role to make the developing world more visible to our students. Now, every year in the world, 10 million children die under 5 in developing countries. And it's approximately the same as every family in California, Texas, and New York losing a child each year. And so I think we have a special responsibility to make the problems of the developing world visible to our students. But I think second, we have a responsibility to lead the innovation of a new type of technology because we just don't have sufficient resources to solve these problems with existing technologies. So it's incumbent upon us to develop new technologies that are sufficiently portable and rugged and cost-effective to begin to meet these needs. And I'm very pleased that Rice will soon be announcing a new seed grant competition that is supported by a donation from the chairman of our Board of Trustees, Jim Crownover, who's here with us this morning. This new program will provide $300,000 to help support new collaborations between engineers and scientists at Rice, between clinicians and basic scientists in the Texas Medical Center, and between scientific and clinical partners in developing countries to begin to develop technologies that meet this need. But I think our third responsibility is not just to develop new technologies, but then to partner with organizations that deliver healthcare services, with NGOs, with industry, and with policy-making bodies so that these cost-effective technologies reach the patients who need them. Now, our conference today grew out of a new program at Rice called Beyond Traditional Borders. And this is a program that's focused on undergraduate students. And really the goal of this program is to encourage students to think beyond the traditional disciplinary boundaries and to think beyond the traditional geographic boundaries to develop solutions that meet the healthcare needs of a global population. We've created a new curriculum that spans the freshman to the senior level, and we've tried to partner with our colleagues in the Texas Medical Center who provide healthcare services in developing countries. You'll hear later from Mark Klein from the Baylor International Pediatric AIDS Initiative, who will talk about some of their very important efforts to deliver services to HIV-positive children. One of the things that we've been able to do working with BPI is to identify design challenges for our students from the freshman to the senior level. And you'll have the opportunity at lunch today to see all of the hard work that they have put in to these programs, and they'll be demonstrating some of their solutions during a poster session at lunch. So really the goal of the conference today is to think about not just how can we develop new technologies, but what are the policy implications that are required to support the development and the implementation of these technologies, and what types of multidisciplinary and multinational partnerships are needed to get these technologies where they are needed. We're going to begin today with an overview of the global health challenges in the 21st century, and I can't think of a better person to provide an overview than our speaker, Dr. Roger Glass. Dr. Glass is the director of the Fogarty International Center and the associate director for international research at the NIH. He took office in June of 2006. He was appointed by the director, Elias Zerhouni. But prior to that, he has a long and distinguished career in international health. In 1977, he joined the Center for Disease Control and Prevention as a medical officer. In 1984, he joined the NIH in the Laboratory of Infectious Disease, where he worked on the molecular biology of rotavirus. His research interests include the prevention of gastroenteritis from rotavirus. He has maintained field studies all over the world: India, Bangladesh, Brazil, Mexico, Israel, Russia, Vietnam, and China. He's fluent and he often lectures in 5 languages, and today he's going to speak with us about global health challenges in the 21st century. Dr. Glass.
Rebecca, thank you very much for that kind introduction. I'm really delighted to be here, and I was delighted to have this invitation to speak at an undergraduate and graduate school campus, not a medical school, but one that's so closely tied to the Fannin and the medical centers here in Houston that this is really a golden opportunity to get you all together. And I'm going to talk about some ideas and overviews of global health for the 21st century. Since many of you will be speaking about issues of policy, ethics, vaccines, new drugs, and the like over the next day and a half. My own interest in global health really began as an undergraduate thinking about cholera, which was the granddaddy of all infectious diseases and the one for which global health began. It was from the quarantine of ships coming from Asia to Europe and then from Europe to the United States that began us with a history of international health law. And it was from studies like this of John Snow, the physician to the Queen of England, Queen Victoria, that we learned that cholera was spread by water before the agent was ever known. Well, having been a history of science major, I decided that cholera would be my first target. And I ended up, and here's the Broad Street pump handle that John Snow removed to stop cholera in England. I decided I could stop cholera in Bangladesh by going out and taking off some pump handles. So I went to Bangladesh with my wife in 1979. I would call this an early childhood experience, an immersion experience, to see what I could do to stop cholera in Bangladesh, a disease that kills over 100,000 people a year. And I found while I was there, and I said, what can I actually learn in Bangladesh, such a poor country. At the time, it was one of the poorest countries of the world. And I realized that in developing the treatments for cholera, oral therapy was established, the physiology of oral rehydration solution, a solution that's saved over 1 million children a year. And all of you who have children have probably had children with diarrhea. You probably gave them oral rehydration solution. You probably never recognized that that was a solution developed in Bangladesh and in India for the treatment of cholera that's become a global treatment. So I realized that not only could we do good in Bangladesh by giving oral rehydration and working on research, but the impact of these discoveries would be helpful at home as well. Well, I got to Bangladesh and I realized that while I had worked at CDC on diarrheal diseases, the study of fat tourists on cruise ships who got norovirus, that didn't seem like a compelling reason to go into diarrheal diseases. I really found in Bangladesh that diarrhea was one of the prime causes of death of children under 5. And in fact, while I went to study cholera, which I saw from afar as the most romantic of the diseases I could study, in fact, rotavirus was by far and away the most important cause of severe diarrhea in children. Furthermore, it was a global disease, so that in thinking about vaccines, and we did make vaccines for cholera, that rotavirus vaccines would actually have an impact in the United States as well as around the world. So here it is, the main causes of death in children in the world and people: AIDS, TB, and malaria, the big 3, diarrhea and acute respiratory infections, primarily in children, with diarrhea caused by rotavirus as a key target. So it was because of this that I really spent the next 20 years working on rotavirus and rotavirus vaccines. If I had been a student and someone asked me if I wanted to spend 20 years working on rotavirus 20 years ago, I would have laughed, smiled, kicked, and walked out of the room. And yet I found it an absolutely amazing event. Rotavirus causes diarrhea, vomiting, dehydration, shock, and death in small children the first few years of life. Over 500,000 deaths a year. 1 in 20 children in the developing world die from rotavirus. So it's clearly a topic worthy of our attention. And I was able to see vaccines developed first with the RotaShield and then with new vaccines licensed last year in Europe and now in 90 countries. And we're slowly seeing surveillance of rotavirus around the world. We have surveillance through CDC and WHO in more than 50 countries today. Vaccines licensed in 92 countries. And we hope over the next several years, with tremendous support globally, that rotavirus will be a vaccine-preventable disease. Well, why do I say this? I mean, when I went back to CDC in 1986, I spoke to the director of CDC and I talked to him about rotavirus, and I told him how important it was in the world. And he said, "Great, we're delighted to have you back." And he sent me a letter saying, "We're welcome back as chief of the retrovirus laboratory." The head of CDC in 1986 didn't know the difference between a rotavirus and a retrovirus. And I realized that we had if the head of CDC didn't know it, heads of countries would not know it. And it was through research at CDC and overseas that we were able to get others interested in rotavirus. In fact, it was rotavirus that first got Bill Gates engaged with vaccines. When he read about rotavirus deaths in the World Development Report, data that we had developed, he scratched his head and he said on Bill Moyers, "Never heard of rotavirus. What is it? If a 747 crashes tomorrow, I'll hear about it for months to come. But if 1,600, 1,800 children a day die of rotavirus, it's a silent disease." And it was because of Bill Gates' interest in what rotavirus was and the fact that it was a low-hanging fruit for vaccine development that really got him engaged in new vaccine development. And from Bill Gates, it went to the Global Alliance for Vaccines, now the G8 and the International Finance Facility. So we've gone from a disease which was unheard of 20 years ago to a disease which is one of the 2 priorities for new vaccine development. So I've gone from, and the lesson for me has been that an early childhood experience, an immersion experience in Bangladesh, was so gripping to me on a disease that's the least sexy of all the diseases you can imagine, but perhaps one of the most important, that we've actually been able to make a difference. Well, I want to move on then to the transition and where we are and give you an overview of how I see global health today. This is a map on the history of life expectancy. And ultimately, for global health, isn't what we all are striving for long and healthy life globally around the world? And this graph, to me, is very interesting because first it shows that the longest life expectancy in the world today at birth is in Japan, about 85 years. You also see that we've kind of a continuous upward graph here, and there's no end to it. There's no reason why we have to die at 85 or 90 or 95. There's a steady uphill progression if we learn how to deal with diseases, many of which are of global proportion. The other feature of this graph is that when you look at the world population range, even in the poorest countries, life expectancy has gone up substantially over the years. In all continents except sub-Saharan Africa, where because of the HIV epidemic, the AIDS epidemic, since about 1992, mortality has increased, life expectancy has gone down. Even in South Africa, where the life expectancy was on the order of 63 years in 1992, it's now on the order of 50 years, 12 or 14 years later. It's declined that much in a decade. So life expectancy is a real good indicator. And I want to show you that another way and where technology plays a role. Here, if you were born in 1900 in the United States, your life expectancy was 40 to 50 years. By the beginning of the 20th century, our life expectancy is nearly 80 years. Our life expectancy has gone up 2 years, 2.5 years a decade for this century. And it's still going up from 1960 to 1990 and to 2000. Second, this graph shows that with per capita income, you don't have to be rich to have a long life. That many countries have reasonably long lives with relatively low per capita income. And then there is a shoulder here of the developing countries where lots more could be done. And that's what we'll talk about and concentrate about over the next day and a half. So life expectancy is rising. Well, what does this mean? For one, it means that the population pyramid has changed. In a developing country, you have a large group of dependent younger children, a smaller working group, and very few elderly. In the developed countries, it's the reverse, and it's the problems of aging that we see here today. Well, how does that affect us? Let's think about China as an example. I've been going to China since 1977. In 1977, there were no cars. There was one hotel in Beijing, one hotel in Shanghai. It was an impoverished country. You couldn't believe the changes that have occurred in the last 3 decades. Life expectancy in China in 1960 was 39 years. By 2000, it was 71 years. An extension, a prolongation of 8 years per decade, the most rapid prolongation of life in the history of the world, of history of mankind. And the consequences on health are enormous. The problems of chronic diseases, of smoking and lung cancer, cardiovascular disease, were not a problem 40 years ago because people didn't live to that age. Today, these are incredibly important, as are environmental health, access to care, and the like. However, the reason it's only 71 years and not 80 is because in Western China, and I visited last year with my sons, Tibet it looks like Bangladesh did 30 years ago in terms of child survival issues. So in order for them to raise their life expectancy, they really have to think about those developing country issues, infectious diseases, like in Africa. Well, the indicators, and these are just a few, per capita income, life expectancy, infant mortality, and the difference in infant mortality, almost a 20-fold difference in the likelihood that a child will survive in an African setting, a poor developing country setting, something that we know a lot about and could change. Also, the distribution between non-communicable diseases and communicable diseases are striking by continent. And really in Africa, the infectious diseases are of tremendous importance: HIV, TB, malaria, diarrheal diseases and respiratory diseases. In the rest of the world, the patterns are changing. And if you look, and this is from the Global Burden of Disease, an activity I'll mention later, if you look at the distribution of causes of death today in the developing world and causes of death in 2020, you'll see that we're moving from many that are perinatal causes of death, respiratory infections, diarrheal diseases, with ischemic heart disease, cardiovascular disease being the #1 killer worldwide, to a pattern where depression is a major cause of DALYs, disability adjusted life years, another measure that takes into account not only deaths but disability, cerebral vascular disease, many other non-infectious diseases, but TB, malaria, HIV, diarrheal diseases still remain problems. Well, what does this mean? It means that today we have 130 million children born, 10 million who are dying. Only fewer than 1 million would die if they had the level of health care attention to infections that we have in the rest of the world, in the developed world. So there's a lot that can be done. And these diseases and these problems for here under 5 mortality, concentrated in Africa and some parts of Asia, fertility of the same series of patterns, HIV prevalence primarily in sub-Saharan Africa, but a global problem. India is clearly a major source of HIV, and access to water. So there's a lot that can be done in the future, to the point where Rick Klausner, who was the former head of the Gates Foundation, made the observation that all of these data that I've showered you with about differences in the world and health disparities were a witness to a terrible time warp in which the great advances of the 20th century have simply left out a majority of the world's people. Well, why invest then, and why should we even be thinking about global health? Is it to protect our borders from infections? Is it to promote scientific discovery? Is it to engender goodwill, a humanitarian effort? Is it for diplomacy? We want to win the hearts and minds of our adversaries. Is it out of enlightened self-interest? We want to make ourselves feel better. Is it to counteract terrorism? I can't think of greater terrorism than the thought of a parent knowing that one of their 5 children will die in infancy, or of a parent who has a chronic disease who will live with that chronic disease, which would be treatable in the rest of the world. Or is it for economics? Is it for competition, that we really have markets abound where we could service them? Well, Tony Fauci, director of NIAID, has put together this slide of the emerging infections. And his answer to this has really been that we need to promote global health to protect our borders. And it's our borders from Ebola virus, from SARS virus, from avian influenza. There are lots of these infections that are threatening the U.S., and unless we have global surveillance for these, we'll never be safe at home. So it's to combat bioterrorism and natural infections that global health is key. Well, and of course, in these diseases we mentioned. I grew up in Somerville, New Jersey, and when I was growing up, the terrorism for me was not SARS or avian flu, but we had Johns Manville in the neighborhood, the promoter of asbestos. And you all know about asbestos, but in that time when I was growing up, it was our local doctors, our LMDs, who made the diagnosis on x-ray of mesotheliomas and asbestosis. And many of these workers were getting sick. And I appreciated when I was at the School of Public Health that their asbestos didn't come from Johns Manville in New Jersey, but South Africa. And it was the mine workers in South Africa that had these exposures. And in fact, we had a lot to learn on environmental hazards reaching our own borders. So many risks were global. And when I spoke to the group at the National Institute of Environmental Health Science, I said that, we can't just concentrate on the infections. These environmental risks are equally important, and there's a lot to learn from understanding these risks overseas. Certainly Chernobyl taught us about the risks of radiation, as did the Hiroshima, the Atomic Bomb Casualty Committee. In my own studies in Bangladesh, we were really interested in cholera, only to find that the 2 wells that we installed 25 years ago to stop cholera and provide clean water, 25% of them have toxic levels of arsenic. And now we have a population with chronic arsenicosis. arsenosis. And if we want to understand the hazards of arsenic poisoning and how to correct it, we really are best served by working in Bangladesh and understanding the disease and its cure. This is a problem for anyone using tube wells in Bangladesh. So there are lots of global exposures that will teach us lessons about what we need to know in the U.S. I was particularly tickled to find this exposure grant we have at NIH in Iran. In Iran? NIH investing in Iran? What for? 1980s, we gave Saddam Hussein mustard gas, and he used this on the Iranians. And now we're looking at the chronic effects of mustard gas poisoning. Where else in the world could this be studied, except in a population that had been exposed? It's a bizarre exposure, but it lets you see that there are opportunities to understand environmental risks around the world. Right after my internship, I went to work with this man, Sir Richard Dahl, probably the most preeminent epidemiologist of the century. When I was a kid, all the doctors, including my parents, smoked. And of course, more doctors smoke Camels than any other cigarette. You knew this. Sir Richard did the study of doctors in England, 35,000 doctors, who he interviewed in the early 50s, and then collected for £1 each their death certificates with the cause of death. He found that in their life, those who were smokers lived 10 years shorter than those who were non-smokers. And they didn't die only of lung cancer, but heart disease and many other cancers. Well, this lesson he had learned by the time I went to Oxford in the 70s, and we said, why don't you say something about it? Why don't you do more? Richard was a pure epidemiologist. He did not delve in politics. That was not in his realm. Just say no and let's move on and do our research. Well, I think the consequences of that research are clear in the United States, where after the Surgeon General's report here, smoking came down, and in one incubation period, about 20 years, deaths from cancer in men came down, and shortly now, deaths from cancer in women are coming down. We're learning the lesson, however slowly. But I want to show you this graph. Here's lung cancer deaths in the UK, and clearly the lesson's been learned, and rates of lung cancer deaths in the same age group have dropped 75% in the UK, an incredible contribution of Sir Richard's work. Here's France, 27 miles away. And the smokers, if you go to France and you go to any restaurant, you're surrounded by smokers, and their rate has gone up fourfold. Is this only in France that they don't believe Sir Richard? How about in China? The Chinese just started smoking now that they have a commercial economy. And Sir Richard Peto, Richard Dahl's understudy, has done estimates that over the next century, nearly 1 billion people in China will die of smoking-related disease at current levels. 60 to 73% of men smoke currently. They're just starting to smoke. Their epidemic will come about in one incubation period, about 30 years. By 2025, there'll be 3 million smoking-related deaths a year, and tobacco will kill a third of the men who are smoking. So over 100 million people with these estimates. It's an incredible hazard for the future, and something that will really cripple longevity and life extension in China. We don't understand the patterns of smoking addiction, how to stop smoking well, but we do know that taxation and a number of public policies that have worked in the UK and the United States might potentially be very cost effective if used in China today. Well, Richard Dahl also went on to think about cancer in 5 continents, not just infectious diseases, but cancer. When we were there, we were thinking about liver cancer, cervical cancer, and for both of these, we now have new vaccines. Hepatitis B vaccines for hepatomas, HPV, papilloma vaccines for cervical cancer. I want to just point your attention to breast cancer, because that's a high risk in the United States, a low risk in Africa, although the breast cancer disease in Africa is much more fulminant, rapid onset, and more likely to be fatal. Why is this so? We have a grantee in Chicago, a Nigerian, Funmi Olapade, She trained in Nigeria. She came to Chicago, and she asked the question, why do African American women develop more aggressive breast tumors than Caucasians? A sort of a simple question, what can we learn from the African experience? Is this a problem of poor access to health care? We all know about the poor access to health care of black Americans in inner cities. Well, she was able to raise this question and look at the tumors themselves. And she found that there are three indicators, genetic markers of tumors, receptors for estrogen, for progesterone, and for HER. And these women are called triple negatives. When she looked in her African women in Nigeria, 70% of them were triple negatives. When she looked at African Americans, 40%. And when she looked at Caucasians, there were very few. And this triple negative tumors are more aggressive and don't respond as drugs. Many of our drugs are geared to hormonal ablation therapy. So there are outcomes of this research that are clearly important for African women in treatment of breast cancer and for African Americans if we want to have therapy that's responsive. So in fact, from the genetics, we can actually learn a lot about personalized medical care, response to treatment, and the whole realm of pharmacogenetics that's just opening. Another one of my heroes when I was in England was Dennis Burkitt, a surgeon who went to Uganda early in his career, another, I will call it, early childhood experience. He set up his surgical clinic and started seeing patients like this young boy with a big swelling of his jaw. And it was called African lymphoma. African lymphoma. He then went to a meeting and met up with Yvonne Barr and Epstein, virologist, who had a new virus that was without an etiologic cause, disease. And linking them together, this was the first cancer that was linked to a virus. Can you imagine that our understanding now of viral etiologies of cancer doesn't come from research in an American laboratory, a European laboratory. It comes from a crazy surgeon who went off on his own to Africa to take care of people and made these observations that were critical and linked them to real science. He went on to find that cofactors for cancer were important, that you didn't get these cancers in areas where malaria was not spread. It was an altitude-related disease. Can you imagine a cofactor found? And finally, he went to Sloan Kettering in the 60s, where they were first working on antimitotic drugs, took back some chemotherapy, and this was the first drug that really demonstrated, and the first disease that really demonstrated that you could cure a cancer with a drug, chemotherapy. And chemotherapy now got a tremendous boost from this knowledge and from this early history, all from global health and applying technology in a developing country setting. Well, and I would say that even though we have this Burkitt's lymphoma, he was terrified that this disease, by the way, carried his name. Would you like to be named for a lymphoma? and this, even though we know the etiology, we have the treatment, we still have a lymphoma belt, and very little has been done to prevent this disease in the lymphoma belt of Africa. There are lots of other cancers that are locally important and from which we're learning a great deal about the etiology of cancer. In fact, the Cancer Genome Project is just beginning with sites around the world to begin to look at the genetic changes that allow cancers to grow, to give us targets for treatment and targets for prevention. So there's a lot that we can learn in new technologies for cancer as well as the infectious diseases. Well, I want to just go on with genetics because we just talked about the importance of genetics. When I worked on cholera, I was surprised to find in Bangladesh that if you were blood group AB, is anybody here AB? If you're AB, you don't have to worry about cholera. You're not susceptible. But if you're O blood group, you're highly susceptible to cholera, tenfold more than if you're AB. And in fact, the area of the Bengal region, the Ganges Delta, has the lowest prevalence of O blood group in the world. It's an area where O blood group people have been harvested for hundreds of years before their reproductive age in high incidence. So that the genetics is clearly important for infections as well as many other diseases. Now, I went to school with Nancy Wexler, whose mother developed Huntington's chorea just as she graduated. Of course, you all know about Arlo Guthrie here, and The Land Is Your Land. He was one of the great, Woody Guthrie, I'm sorry, one of the great folk singers of our time. He ended up with Huntington's chorea, and for 13 years he hung on, refusing to give up. It's a terrible, devastating neurologic disease that develops late in life and ultimately brought him to his demise. About 30,000 people have Huntington's disease in the United States. Several hundred thousand have the gene, and it's a dominant gene. What does this have to do with global health? Well, Nancy Wexler up here was a gene hunter, not a virus hunter or an environmental risk hunter or a cancer hunter, but a gene hunter. And she, since her mother had Huntington, she had a 50-50 chance of having the disease, as did her sister. Her sister wrote a book, Mapping Fate. Nancy wrote a book about gene hunters. But they found in Maracaibo, outside in Venezuela, a group of families who all emigrated from, or all were related to a single woman who emigrated to Venezuela in 1824. She developed her disease late in life, but had many offspring, and they had many offspring, and they had many offspring. So through Nancy's studies, she was able to screen about 18,000 individuals, collected 4,000 blood samples, and ultimately in the early 90s identified the gene for Huntington's. Not in the United States, but in this little consanguineous group, a little population group concentrated without migration for Huntington's. Well, that gene was discovered, and that gene in those families led to the discovery of many other genes, including those responsible for Alzheimer's disease, clearly an important problem in the United States, kidney cancer, neurofibromatosis, ALS, amyotrophic lateral sclerosis, dwarfism, and others. So that the genetic prospecting is clearly important and is very critical in areas where there are consanguineous marriages and where recessive genes will come out. So it's really from studies in global health in Maracaibo that we've learned about the genes of Huntington's, and where when we have treatments for Huntington's, we'll be able to introduce these treatments. I want to end with a few ideas about Fogarty, because I left the diarrheal field 9 months ago to see if I could practice some of the lessons I've learned in the global health arena. Fogarty was a bricklayer from Providence, Rhode Island, who worked tirelessly for the cause of global health. He became a union leader and was in Congress for 25 years, contemporary of Jack Kennedy. And he really set up this institute to address global health challenges through innovative and collaborative programs for research and training. And here we are, we're one of the 27 institutes of the NIH, and we're probably the one that's the smallest of all the institutes. This is where global health sits today in our budget's about $70 million a year. We have another $30 million that comes from associated programs with other institutes. And it's really been flatlined for a couple of years because of a number of political reasons, which means that we have to be incredibly economical and resourceful with what we have. We have programs in 60 U.S. institutions, 100 foreign institutions, primarily in the developing world. They're focused on the developing world. When I got to Fogarty as a new government bureaucrat in NIH, I realized that I had an alphabet soup of programs to deal with. But they all had several common themes: collaborative research, training of foreigners in the U.S. on global health issues, training of U.S. academics and students, and development of institutional capacity abroad. And I want to just decipher one or two of these programs because they clearly have importance for you here. One is the first program we had extramurally was called the ATRIP, an AIDS International Training and Research Program. This was a simple program to invest in leaders in global health in 1988, a time when HIV was a domestic disease of hemophiliacs, gays, and Haitians, and people didn't think about AIDS overseas. It was Fogarty that took the fight for AIDS overseas. And the people that we invested in 20 years ago have really grown up to become leaders in the field globally. All of them are still working on AIDS. They all many have had extraordinary careers working and understanding the epidemic and beginning programs of treatment, research, and prevention. We also have another program which would be nice for Rice, which is called the Frameworks Program. This is a gluing program that gets academic institutions together around the common theme of global health, to glue together schools of public health, medical schools, business schools, clearly important, law schools, schools of journalism, nursing, undergraduate curriculum to develop programs where global health will begin as an undergraduate course and continue, really opening our borders, extending our borders, just like your program here at Rice. We have about 20 of these in the U.S. now. We're refunding that next year, and I think it's our landmark program. Another observation I made as I go around the country and think about global health is that all of America's leaders in global health today have three things in common. One is they all had an early childhood experience. They all went someplace in the developing world early on, got so gripped by that experience that it changed their life, and have stayed with it ever since. The second is they're all white males. You notice that this is 30 years ago. And the third is they only have worked at infectious diseases. And clearly in the 21st century, we're going to be extending beyond the infectious diseases to the chronic diseases as well, although the infections remain incredibly important, particularly in Africa. So how do we create the next generation of leaders? We have the Fogarty-Ellison program, 25 medical students we send abroad. We're now competing a program to send fellows, residents, and junior faculty for these early immersion experiences. And I'm looking forward to Mark Klein's presentation because it's a wonderful model to follow. And we send these people to 16 sites. So Fogarty has been a little bit like the watering can for global health, promoting research and training and trying to extend the reach of global health in Congress, in the United States, and abroad. How do we decide and focus on the real killers? There's been a lot of attention in the U.S. on these diseases which affect our borders: SARS, West Nile, smallpox, anthrax. You've heard them. They all have killed fewer than 1,000 people in a year in the world or in the United States ever. Whereas these other diseases in the developing world kill over 1,000 children, people a day. So we have to adjust our priorities. We just completed the Disease Control Priority Project that focused at CDC, but with support from the World Bank, the World Health Organization, the Population Reference Bureau, led by Dean Jameson, not a physician, not a public health nick, an economist. And really, we recognize that economists have an incredible role to play in extending the reach of global health. They've come up with a series of best buys. There's in global health, half are infectious, half are in chronic diseases. And these are on the web, available to ministries of health and academics and students to think about programs in global health abroad. And the website for this is DCP2. You can get the $250 book absolutely free by downloading your chapters from the website. Finally, I want to end with health diplomacy, because the Lancet said that health is now the most important foreign policy issue of our time. In this current presidential administration, we've had more money in the PEPFAR program, the President's Malaria Initiative, in efforts to control emerging infections and flu than ever before. So it's really a boom time for global health. We've had the Indians and the Chinese, who used to be recipients of donations, who are now funding their own research and really just need ideas and direction to work with them. They have money, they just need support. So with Professor Bond and the Minister of Health, we've signed with NIH agreements in biotechnology. We're signing eye disease, cancer, HIV, child health, and the like. They're funding the research. We're providing ideas, support, and people. We have collaborations here on the genetics of hearing loss between Palestinians and Israelis to understand the genetics of deafness in consanguineous Muslim communities in Palestine. Where else can you have Israelis and Palestinians working together? Soft diplomacy. And here we have Arash Alai, an Iranian physician who came to NIH in December, who collaborates with someone from Harvard and someone from Yale on HIV and TB control. Wonderful collaboration. When else can you get Harvard and Yale to collaborate than with an Iranian? So who are our advocates for global health? We have the richest man in the world, the most visible man in the world, a couple of presidents, the Europeans. There's a tremendous upsurge of interest globally and on U.S. campuses for global health. There's money in global health since the Gates' original contribution in the last decade, more than we've ever had before. And the challenge for us is to use this judiciously. Where does Fogarty fit in? Really, global health will require partnerships with many groups, NGOs, foundations, other parts of NIH, the developing world, international agencies, and industry, all of them to move the agenda of global health ahead. We're in the end of our strategic planning activities at NIH and Fogarty. We really want to focus on training the next generation of U.S. researchers and foreign researchers, on building sustainable capacity, on promoting implementation of some of the ideas we've learned, on providing support for physicians and scientists to go back home, partnering with everyone, and strengthening institutional capacity through twinning programs like you have here. We're really at a tipping point for global health, a time when an idea has become so well developed that it really tips the scale and you come up with a new product, a new idea, a new initiative. Why invest in global health? We think it's good for science. It's really a new frontier beyond your borders. It's good for diplomacy. It's good for humanity. It's correcting health disparities. It's good for business and competition of the U.S. It's good for our war on terrorism, and it's good for our own future. It's just the right thing to do. So we're working on themes for Fogarty. Science anywhere helps people everywhere is one of our thoughts. Take science where the problems are, or science for global health, and we're just at the end of our strategic planning activities. Thank you very much for your attention.
Time for questions?
I've stopped all questions, huh?
What's the role of education? I read that expenditures on education are almost as important at increasing health outcomes in developing countries than our direct expenditures on improving access to health. What do you think?
Education is clearly very important. What's happened, what's been interesting for me to observe, Dean Jamieson has been our lead economist for this disease control priority project. He really began with education as one of his areas. What's the impact of education on economic development? He turned his sights in the early 90s to economics and health. And he's found that investments in health have almost as good a return or better return than investments in almost any other sector. You're getting an improved workforce. They talk a lot about the demographic transition. With the boom, with a smaller number of young children, a smaller dependent population, that's led to a swelling of the group, the labor force, basically, which has led to some of the boom in economic development in Asia. So clearly economics of health is important. Economics of education goes right along with it. I'm not really in a position to compare the two, but I would have you go back to Dean Jamieson because that's really where he started.
Thank you.
Yeah.
I just have a minor comment on expected increases in life expectancy. I know Nevin Scrimshaw and Bob Fogel and others are sort of looking into some of these issues, but I think the fact is that with the increase in obesity, both in developed and developing countries, it's quite likely that the maximum life expectancy, at least for the foreseeable future, has been attained in countries like Japan. The other point I just wanted to make was breast cancer. We know diet is very important. In fact, when you put the map up, you can see that Australia and the US, the percentage of energy coming from dietary fat is over 45%. And these are the countries. So I agree the role of genetics, but I think in some sense, because genotyping has become so cheap, there's an effort to employ those methods and not even look at biomarkers and so on. So I think in some sense it's a good development, but on the other side, it could also be counterproductive from a policy standpoint.
Yeah. Good comments. And I would say that in a half an hour I can't cover everything, but the prevention of cardiovascular disease has got to be number one on top of the list. And what does that include? Part of it is antihypertensive drugs, something we've known about for years in the United States. We use it haltingly. Some of us take antihypertensives, some of us don't. though we should. So it's an area that we haven't fully exploited. In the developing world, no efforts towards the prevention of cardiovascular disease or stroke with antihypertensive. Obesity is, my daughter spent the summer in Peru at the Institute of Nutrition with Claudio Lanata. The institute was set up to study malnutrition. Now my daughter was there to study obesity in the same population. Here you have a population in transition. Rural areas, urban areas, urban settlements of Peru, of Lima, with malnourished people and obese people. Obesity is an incredible problem in the U.S. and could be one of the factors and features which delays the prolongation of life in the United States. So it's become a hot topic now. It's beginning to be addressed. The time to address it will be shorter than the time to address the problem of smoking. In fact, the Surgeon General, Richard Carmona, the last Surgeon General, issued the first government report on the harms of obesity and its importance. So it's just the beginning.
I'd like to ask about the 10 best buys. The absence of clean water and improved sanitation. Is that not on the list because it's not considered a good buy? That's the first question. And then just a comment about cardiovascular disease. I know it's not within the reach at this point in developing countries, but lipid-lowering agents have in fact revolutionized management of cardiovascular disease in developed countries now. I mean, it's really amazing. So if these drugs were available, it would probably have a huge impact in developing countries as well.
The problem of clean water is clearly huge, especially in parts of Africa, as the slide suggested. There are lots of efforts to improve clean water. The World Bank is heavily involved. We went through a clean water decade in the 1980s with very little outcome. It's very hard to get people to change their water systems. In my own field of diarrheal diseases, I really went to Bangladesh to work on clean water, to work on the pumps. When I found that rotavirus was so common, that rotavirus is a problem in the U.S. as well as Bangladesh, clean water is not the difference. But a vaccine could make a major impact in reducing by about a third diarrheal deaths in that country with a cheap and simple intervention. So rotavirus becomes a best buy, whereas water is a much more expensive but good buy. On the cardiovascular, the importance of the poly pill has come up repeatedly in the global disease burden estimates. The use of statins to change the lipid profile, to improve the lipid profile in the prevention of cardiovascular diseases is critically important. And I think that every man and woman over 55 should be alert to this literature and should have at least considered the components of the poly pill, which are aspirin, a statin, antihypertensives. How does this play out in India? Well, one of our grantees is Prabhat Jha, and he's trying to get a poly pill intervention in India. India has one of the highest incidents of cardiovascular disease at young age, so that my colleagues in Bangladesh and India who are my age have already had their first and second heart attack, if they're not dead already. Why does it occur early? And could it be prevented with a therapy with a poly pill? This is being now discussed as a possible intervention. Can you put an entire society on drugs? This is something we've never tried before. We're just beginning to see an impact in the U.S., but not on the national program. Could we do this as a public health intervention in a place like India for a generic and cheap poly pill? That's really a question that hopefully will be answered in the next few years. Yeah.
A major impediment in many of our countries is migration and brain drain. Is the Fogarty program trying to address this? Because there's no point spending billions of dollars training professionals only to lose them to the developed world where they are not really needed.
Yeah, it's only been the last few years that the importance of the brain drain has raised its head as a major problem. with our Fogarty grants, about 90% of our grantees end up going home and working on programs like the A-Trip and becoming leaders, in part because their attraction to go home is that they have a good job, they have a connection with an American institution for their research and activities. But that doesn't address the health manpower. I was just reviewing, there was an editorial in the New England Journal about the Aga Khan University. Something like 70% of graduates of that wonderful high-quality university in Pakistan are now in the United States or the UK. We have a program of re-entry grants that we're using to get people to go back to the country for research. When I spoke with the head of the Department of Biotechnology in India, I mentioned this to him because we have over 100 Indian postdocs on campus. He's looking for good scientists to populate research institutes in India and hospitals. He said, I like that re-entry grant idea, and he just put together the Ramalinga Swamy Awards to bring Indians back for training. In Africa, the exodus of physicians and nurses is enormous, and we really need policy studies to figure out how best to create opportunities to keep people who are already trained working productively in that setting, and to train the numbers that are needed for the next generation. When we put many of the population of Africa on antiretrovirals, that can't be done without manpower to maintain it. So I think it's a critical question for the future. It's just beginning to be addressed, and hopefully the English have come up with some ideas. Ideas are circulating. We don't have a clear answer yet.
Roger, one is a comment and one is a question.
Yeah.
And I know certainly the Fogarty Center, given your budget, that you can't deal directly, but indirectly with pressure. I think particularly from the private sector, that would be, how do we maintain a health infrastructure in the developing world? How do we put it there? Obviously, the people that are needed to staff it's the other issue, but we also have to have it, and that has been just an enormous problem. How do you see that evolving?
Part of that disease control priority project is a chapter from Ann Mills and a section on delivery of care and sourcing of delivery of care. It's an area that probably has received the least amount of attention. I mean, we're really good on biotech interventions, bioengineering. On strategies, we're really in the area of labor economics, public policy, and the like, to create the incentive to have people stay where they are and be gainfully employed. I don't have a clear answer to that one now. I'm only 9 months on the job, so I'm learning. But I must say that in my own experience in Bangladesh, and I've been going to Bangladesh for 30 years, when I started there, immunization coverage was 5%, family size was 6.2 children per family, life expectancy was about 45 years. Today, women have 2.6 children, not 6. The immunization coverage is 80%, not 5%, and life expectancy is over 60 years. What has happened? What has happened to me is impossible to appreciate is that women have entered the labor force. When I was there, women in this strict Muslim society did not go out of their compounds after puberty. It was quite limited. When the garment industry set up in Dhaka in the mid-'80s, women 13 to 21 would exit their homes and go work in the garment factories. They have an employment, they have a doctor on site, they have a source of income. They can't get married early because they would lose their salary. They can't marry someone who doesn't have a salary because it's marrying beneath you. They have an independence. If they don't like their husband, they can walk away because they have some place some way to support themselves. So that is, garments have become the #1 industry of Bangladesh, and through that, we've seen an incredible change in the health outcomes of Bangladeshi population. And the thing that's striking to me as a health professional is it wasn't a health intervention; it was the employment of women. So that's another undersourced area that's critically important.
I really hate to shut down such an exciting discussion, but one of my other jobs is to keep us on time today. Thank you so much for that wonderful talk. We're going to turn now to consider some of the policy implications of new health technologies, and we have two very interesting talks with, I think, very different perspectives. The first talk will be given by Dr. Eduardo Sanchez, who is the director of the Institute for Health Policy at the UT Health Science Center at Houston. He has a very long and distinguished career in public service. From 2001 to 2004, he served as commissioner of the Texas Department of Health, where he oversaw programs that were related to disease prevention, communicable disease control, and preparedness to environmental and consumer safety issues. From 2004 to 2006, he was commissioner of the newly formed Texas Department of State Health Services, which combined public health, mental health, and substance abuse programs. He's received a number of awards for his work, including the Public Health Award for his contributions to public health in our own state. So I'd like to welcome Dr. Sanchez.
It's an honor to be here, and it's an honor to follow on the heels of Roger Glass. The connection is pretty uncanny. I do have an undergraduate degree in biomedical engineering and a master's degree from Duke University in biomedical engineering, and never would I thought that I'd be a part of a conference that was birthed, if you will, out of a bioengineering department. And so I'm really pleased to be here. I had the opportunity to spend a summer involved in a program in Houston doing research at MD Anderson, and I lived here on the Rice campus during that time, so it's good to be back. I had early childhood experiences. My family is from the Dominican Republic, and I have a family that spans the socioeconomic continuum, and so had opportunity to see how not necessarily the richest, because I certainly didn't have any of that in my family, but saw how those with means and those with less means lived and how they handled health issues. I had a young adulthood experience as well. I had the opportunity as a medical student to spend a summer down in Brownsville, Texas, and work with a former commissioner of health, David Smith, and saw that the challenges of the developing world are very much still inside our geographical borders. Down in the lower Rio Grande Valley, as some of you know, people who live in the United States live in colonias, developments that often do not have electrical power, water systems, and where diarrheal disease can be tracked with rains. And then I had a middle adulthood experience, not ready to say I'm in late adulthood quite yet, and that was as commissioner of the Texas Department of State Health Services, in other words, as the state health officer in a border state. I served on the U.S.-Mexico Border Health Commission and actually served on an international body whose charge was to look at and address, assess, and try to make a difference on border health. And it was interesting to try to align initiatives on the north side of the border, south side of the border, and try to tackle some of the very issues that I think the notion of integrated global technologies is trying to address. I am here representing the University of Texas School of Public Health. We do have degree programs with a global health concentration, trying to look at how globalization affects the determinants of health and health status, and I'm going to talk about that in a little bit. Developing global awareness to develop public health leadership and decision making, and developing ourselves into global systems thinkers, and we certainly had opportunity to think about that with Roger's presentation. Palmer Beasley, whose picture was up there, is a former dean of the School of Public Health. So let me start with the following. Integrated technology solutions are a means to an end. We need to remind ourselves of that not only when we're talking about international issues, but also when we're talking about issues domestically, that sometimes the things that we focus on are nothing more than a means to an end, and it's just my opportunity to say that ensuring all Americans in the United States is not the answer. It's a means to an end. And so as we think about integrated technologies, it's how we apply them and how we put them in appropriate settings. And at the end of the day, the objective is to advance global health. It's interesting that Roger talked about global health in the context of diplomacy. As the U.S.-Mexico Border Health Commission member, I had the opportunity to work with Secretary Tommy Thompson, who said over and over that health is currency for diplomacy. It is a place where even countries that might be at odds with one another, we heard about the relationship with Iran, there is still opportunity to sit and try to figure out how one might come up with solutions that serve populations. This is an appropriate time for me to talk about the challenge of policy. And the challenge has come and slapped me in the face many, many, many times. I'm a scientist, I'm a physician, and I'm somebody who believes that when you have the evidence and there it is, the next steps are obvious. Of course you're going to do that because that's what the science says and that's what the engineering tells you can do. And I like to think about taking science and engineering and converting it into policy as it's a video game, and there's four levels that you have to deal with as you go through that video game. The 4 P's. The first one is perception. Is it a challenge? Is it a problem? Is it something that needs to be addressed? And I'm pleased to see on the poster board that's sort of the first step, statement of the problem. Then there's practicality. Can you do something about it? And again, I'm very pleased to see that the poster session shows a number of ideas that have been thought about in the context of practicality. The third one is price. What's it going to cost? And again, I saw cost analysis on every one of the poster boards, and that's, again, very, very important when you're talking about applying a technology that we've developed in the United States to another country. The price differential may just make it completely prohibitive. And then the last P, not the least favorite of my P's, and one of the reasons that I'm really glad I'm not a state health officer anymore, is politics. And politics is the big trumper. In politics and state government, and even at the national level, we may think it's nasty, but I'll get to this in a moment. Politics on the national scale and the international scale, now we're talking about wars, we're talking about governments that don't necessarily go from one to another in a peaceful way, and that is not fertile ground for the kinds of things that we would like to see, and that's the advancement of global health. So let me put a definition up here and say the health of a population is measured by health status indicators and is influenced by social, economic, and physical environments, personal health practices, individual capacity and coping skills, human biology, early childhood development, and health services. It's pretty complicated stuff. We often use mortality as a measure, and I'm going to go through leading causes of death by broad income group in high income countries, and you can see that coronary artery disease and stroke, if you add those up, is about 27% of deaths. If you add up the cancers, that's about 13% of deaths. 40% of deaths then in the high income countries, and that's certainly true in the United States, are cardiovascular disease, cancer, and stroke, the way we categorize them in this country. But when we think about the actual causes of death, not what we diagnose people with when they die, but what are the things that cause those deaths, and we heard a little bit about it. In the high-income countries, those actual causes of death are tobacco, sedentary lifestyle, poor nutrition, or maybe too much nutrition, and then third, immoderate use of alcohol. When we look at the low-income countries, things change. And you could see that infectious diseases populate that list of 10 leading causes, but interestingly, coronary artery disease, coronary heart disease is still at the top. And coronary heart disease and stroke combined about 17%. Infectious disease, however, 31% of the 10 leading causes of death. But again, health status is more complicated than just mortality. This really doesn't tell us everything we need to know. And I'm going to put up a kind of a busy slide. And it's busy because I still haven't mastered PowerPoint technology. And when I was a state health officer, the only PowerPointing I did was with my index finger. But what I wanted to show on this slide is that if you look at 5 countries that I've compared, China, Dominican Republic, Nigeria, Mexico, and the United States, you can see GDP, and I don't have a pointer, but GDP is very telling. You can imagine it's sort of 3 tiers. USA is at the top tier, about $40,000 a year. Then you've got Mexico, Dominican Republic, and China kind of represent the 3rd tier, going from about $5,000 to $10,000 a year, and this is per capita GDP. And then you've got Nigeria that represents low-income countries where GDP is about $1,000 per capita per year. Then we look at longevity, and we heard about this before, and in fact, again, some of what Roger says is borne out here, and you could see that longevity in Nigeria is extremely low at that's the other thing is I never learned how to use gotcha. So what you can see is that longevity in Nigeria is about 45 years. Health costs, and that really is health expenditures, per capita, $51 per person per year. The 3 other countries that are not the United States, somewhere in the hundreds. United States, we're up at close, it's actually $6,670 per year, latest figures. And then when you look, one other marker that I looked at was physicians per 100,000. And again, the United States, you've got 2.5 physicians per 100,000. In Mexico, Dominican Republic, and China, it's between 1 and 2. And then when you look at Nigeria, you've got a fraction of a physician per 100,000. So the challenges are great. I think that restates and sort of, it's a different way of looking at what is clearly at least 3 tiers. Developed countries, developing countries, and then the underdeveloped countries. And those that are in the middle are closer in terms of at least health status, some health status indicators, than the really low income countries are. We heard this stated a different way, and that is that perhaps we need to think about our priorities, and that in order to maximize population health, societies ought to pursue interventions in proportion to the ability of those interventions to improve outcomes. We were talking about the use of applied technologies, the polypill. The polypill is perhaps a much better intervention than trying to build cardiac cath units in many of the countries that we're talking about, because even in those middle countries, the Dominican Republic being one, the power grid and the water supply is such in many parts of the country that I know of situations where people have been in hospitals where there's power outages for hours at a time, some of the better hospitals in that particular country. So one could argue that perhaps food security is something that we ought to think about. We talked about education. At least in this country right now, higher education is correlated with higher health status. And it may be the case that in countries where there's more economic opportunity, that's more of the case than in a country where perhaps the economy is more agrarian and only partially industrial. Education may not make as big a difference as it does in the more advanced nations. Those are things we need to think about as we consider policy, appropriate technologies, and global health. So where does basic public health and medical care come in? And I would argue that perhaps we could think of a Venn diagram with 3 circles, and the sweet spot, if you will, the middle, that part where all 3 intersect, is going to be the place where food security, education, and health systems are maximized. Now, Roger mentioned environmental issues, and this is but one perspective on that very issue. This was an article in the New York Times earlier this month basically saying that Africa is going to bear a disproportionate brunt if indeed global warming is going down the path it's going. And if it is, then water and food security are going to become even bigger issues. And if water and food security are at least part of the basic elements that we need, just investing in health care may not be quite enough. My colleagues at the School of Public Health are authors and editors of this book, Reinventing Public Health, and I want to use it to frame some of the policy issues that we ought to be considering. First is the thesis that to effectively improve population health and reduce health disparities, policymaking must take into account the fundamental social, economic, and ecological determinants of health. We don't just plunk down on the planet. We do plunk down on the planet, and where we're born has a lot to do with what our health status is likely to be. Public policy here is defined, and I want to define public health as what we do collectively as a society to assure the conditions in which people can be healthy. So let me repeat that. What we do collectively as a society to assure the conditions in which people can be healthy. That doesn't necessarily mean medical care. That doesn't necessarily mean traditional public health. Those are really, really important. But what I'm saying is that it suggests that there's other things that we ought to think about when we consider what it's going to take for us to be healthy and for us to achieve global health. So in the domain of the fundamental determinants of public health, you've got natural capital, and that has to do with environmental resources, both what you have and maybe what we take for granted and might be affecting adversely. And here in Houston, Texas, our air is not what it ought to be, and fortunately our mayor is looking at how we might improve air quality. But you can imagine that in other places, as we heard South Africa, asbestos, there's the issue of what we're doing to the environment as well as what our environment may have that could help in these other arenas of food security and water supply, basically by being currency that can be used to purchase and or build. Human capital has to do with education. Material capital is what you do with that education. We know that if you are educated in some countries of the world, your opportunity to do the things that you might do in other countries is very, very different. And so just having the education doesn't mean that that translates into a good job with a good income. And then social and cultural capital, that has to do with community empowerment. And again, I think we could all imagine that there are some places in the world where right now community empowerment can't happen. In the midst of war, in the midst of political turmoil, it's very difficult for people to have even a sense of being able to get together and in a peaceful way address issues that need to be addressed. So some of the policy domains then related to these fundamental developments, first is public health, and in spite of what I said, there is value in investing in some of the basic public health measures that that I will actually address in one second, immunizations being one of them, but then some that we don't ordinarily think of as being public health. Human development is not just about education at the university level, and it's about all of it. It's about that early childhood development, those key years early on where children ought to be exposed to high degree of stimulation. It includes pre-K. It includes K through 12 so that a young person has the capacity to pursue a job and or higher education. Community development, again, is the process that serves to empower individuals and groups as citizens in collective actions aimed at positive change. You can't do that when you are in the midst of migration for whatever reason. It could be for environmental reasons, the expanding deserts, migration due to economic realities, people leaving rural areas. Heard a very interesting presentation a couple of days ago about how Mexico has a very large agricultural industry, but the income associated with that is not sustainable. So people move to cities, and I imagine that that's true in many, many, many of the developing countries. And then sustainable development, critically important. And that's economic vitality while making sure that we're taking care of our natural resources. And we're grappling with that again when we think about the petrochemical industry. We're grappling with how we manage to make good use of petrochemicals and at the same time protect our air and protect our health. So I want to talk about 10 great public health achievements in the United States. And I want to focus on the United States only because it can serve as a means for us to understand how we might invest in global health and what technologies we might invest in. And you will see that there are some things here that indeed have been addressed in the poster session. Vaccination at the top of the list. You got motor vehicle safety and safer workplaces. Control of infectious diseases. Obviously, that's of prime concern when we think about the fact that in the developing world, infectious diseases are what's doing us in. And I'm going to talk in a minute about hand washing, what we know about hand washing and how even in America we're not doing as good a job as we can, and how even that may present opportunity to make a difference in what it is that we are able to do with appropriate technologies or the appropriate use of technologies. Healthier babies and mothers, family planning, fluoridation of drinking water, recognition of tobacco use as a health hazard, and I'm going to talk about that in a moment. Those are considered to be the 10 great public health achievements in the United States. Many suggest that in the 30 years of added longevity from 1900 to the year 2000, perhaps 20 to 25 of those years are the result of these public health interventions. So how do we take that and apply those concepts that were learned here over 100 years and use the technologies that are being considered to maybe apply some of those achievements? I had the chance to look at the report of the World Health Organization Global Observatory for e-health, and looking at information and communication technologies. And here were some of the key findings, and this is very, very important. There's been growth in e-health since the year 2000 globally. But as you can imagine, there's been more growth in e-health in the developed and developing countries than in those that are low income. The developing countries are going to require some guidance and some resources. And I'm going to talk a little bit about brain drain. Brain drain is not only happening in the health realm, it's absolutely happening in the technical realm. And so these are countries that are challenged and are more challenged because the best and brightest are moving away and finding it hard to stay in their countries. E-health policy formulation is moving forward, but e-health governance mechanisms are not in place. And what does that mean? Sharing of information. And in fact, the United States and Mexico, as we've talked about how we could share information about infectious diseases, share information about other morbidity and mortality measures, one of the issues has to do not only with how we define clinical cases, but the rules and regulations that our governments have in place that sometimes inhibit the sharing of information across borders. Even when populations are being affected by one disease. Dengue fever is something that was affecting Brownsville, Matamoros several months ago, and our ability to share information was hampered for a while. We are slow on standardization and interoperability. Same thing, but different focus. The first was kind of regulation-based. The second is more technical-based. And we're not at a place yet where we have systems that are completely compatible with one another. But there are applications that are growing. Online information is available, and we make great use of that in the United States. E-journals for health professionals, and when we think about how do we train professionals in other countries, e-journals and e-learning are ways that we might be able to do that. Already in Texas, we do long-distance learning. I teach a class where I'm in Austin, but I have students in Houston and in San Antonio that are participating in real time in the class with the use of information television. Online information that topic reminds me of the issue of health literacy, and again, that's very, very adeptly addressed in the poster sessions. But just to give you a sense of the challenge, and I'm going to use U.S. statistics. Information on the web is written at a 12th grade reading level in the United States. The average reading level of the average American is an 8th grade reading level. The average Medicaid recipient in the United States reads at a 5th grade reading level. So the technology can be used, and if we apply that to developing countries where perhaps people can't read, we've got to think about how we can apply the technology in a way that's useful and be able to help people make the decisions that they need to make about their own health or the health of their families in a way that is relevant to them. So when we think about policy considerations, just a few. There's the workforce issue. And not only brain drain, how do we keep people in countries or get them back to countries, but also what should the distribution of the workforce be? How do we go about, or should we go about, developing community lay health workers as an example? What should the distribution be of specialists, researchers, primary care providers? Should primary care providers be doctors, advanced practice nurses, something less than that depending on the setting? And those are conversations that need to be had in the developed world as well as in the developing world. And how do we go about doing that? How do we build capacity? How do we support that? And technology may allow that to happen. One could have lower level, and I don't want to use that word, we could have community lay health workers supported by nurses who are doing protocol-driven care, but who can be provided oversight in the event of an event. And this already goes on, but with the use of telephones and the use of telemedicine, where you could actually use camera technology to be able to see what's going on, because there are some conditions where being able to see or speak to the patient is very, very important. Technology could be applied in that way. Infrastructure, and I put water and power. You got to have electricity, and electricity and water help us use technology better, and we've got to keep that in mind. So some of our solutions may be may need a regular source of electricity. And again, I saw in the poster session some of the applied technology takes that into account, and then that led to the development of the particular idea. Cultural considerations, I put religion, but there's many. And in fact, context and culture are very, very important. And Roger, I think you would probably agree, and probably everyone in here, you also have to know what your audience is, even as you're involved in a project in another country. There's the culture of interacting with government, and there's the culture of interacting with non-governmental organizations, and then there's the culture of interacting with the people. And you've got to take that into account, understand that that may not be what it is in the United States, and even as we think about policy, that's a very, very important consideration. Legal considerations. And one that I put up there, intellectual property rights, not to speak of the kinds of legal considerations that go with being in a country, bringing medical equipment or pharmaceuticals into a country, things that are easy in some settings, not so easy in others. And in some settings, you just sneak it in, and in others, you work to have a relationship that you can bring it in legally. And in Mexico and the relations between the states, and I interacted with 4 counterparts, we would sometimes agree that the non-official way was going to be more expedient and take care of the business that we needed to take care of. And then there's the political realities. National governance being one. And what I mean by that is one of our guests from the health minister from Nigeria is not going to be here because Nigeria is in the midst of a presidential election, and that's a great thing. But there are countries in this world where there aren't presidential elections, and the transfer of power, when it does happen, happens violently. Those are realities. And in fact, I had the opportunity last year to hear a presentation by a person who was working for Doctors Without Borders, and found himself having to evacuate and leave clinic settings because different warring factions were coming in or leaving places, and they would move like the tide. So when the warring faction, whatever it was, good or bad, whatever it was, moved out, kind of like when the tide goes out, they could build the sandcastle. But when that warring faction came in, the sandcastle was destroyed and they had to take down whatever infrastructure they built. So even the notion of infrastructure has to take into account the geopolitical realities. So some of the essential elements for policy change. You have to have that foundation of science and technology. You've got to have a strategy. You've got to have a message. Timing is very, very important. Relationships are very, very important. And I'm going to stress now and again, evaluation is vitally important. You got to measure where you started, and you got to measure what happened when you were there. I'm going to talk about two things. One, the Truly Clean Hands campaign in Ghana. That was a low-tech intervention, but using technology. It was a public-private partnership, and I think it's very important that we remember that we can and ought to be looking at relationships with governments, but also with the corporations and non-governmental organizations inside countries. And this particular partnership was with soap manufacturers. They made use of technology in this campaign because they found that 66% of mothers watch TV weekly, 85% of mothers listen to radio weekly, and if this is anything like the Dominican Republic in terms of power, it's weekly because you don't know on any given day whether you're going to have power, and you just sort of watch when you can. It was a multimedia campaign that included not only use of television, but also direct-to-consumer, in other words, visiting communities and actually having one-on-ones, and then providing resources in other places where people might be. And this multimedia campaign resulted in the following: a 13% increase in hand washing following toilet use, a 41% in hand washing before eating. I'm a little dismayed when I read that on the face of it, but we in this country aren't doing the best job of washing our hands, even in settings where all of us would like to think people are washing their hands regularly. We have to remind our physician colleagues and those working in hospitals about the importance of washing their hands because they're not doing it 100% of the time. I'd be satisfied with 99% of the time, but it's not anywhere near that. So hand washing is an issue, and we know that hand washing helps reduce the transmission not only of diarrheal diseases, but many respiratory diseases. The Institute of Medicine, Roger talked about cancer a good bit, and the Institute of Medicine has developed a report looking at controlling cancer in low and income middle countries, and I'm going to talk about points 1 and 3. Assessing and monitoring the cancer burden, very, very important. And then cancer prevention, these are some points that were mentioned. Tobacco control could go a long way to reducing the burden not only of cancer but also of cardiovascular disease. And as was mentioned, there are vaccines that have been developed for hepatitis B, relatively inexpensive, for human papillomavirus, slightly more expensive. And here I am at the end of the presentation, and I say there's at least 4 policy questions that we might be considering. Who's going to pay, and how is that payment going to happen? Again, that gets back to that P price. We got to think about how we're going to make it happen. We also have to think about sustainability. If it's a one-time deal, we have to think about whether this is a pilot that's going to help us replicate and disseminate, or whether we're just going to go in and walk away and that intervention doesn't have the sustained power that it can have over time. What should we be buying? And I would say to you that we should be buying population health first and foremost, but that means we've got to be thinking and mindful of those other determinants of health. Why spend the money? And I'll go to point number 3, which was the way Roger ended. It's the right thing to do, and how do we know it's working? By always investing on the front end on the evaluation piece as we do pilot projects particularly, and then monitoring ought to go on for projects that are ongoing. 2 quotes: only a life for others is a life worthwhile. And the last quote: while you cannot do all the good the world needs all the good you can do. Thank you very much.
We're going to do the questions for both of these talks at the conclusion. So we're going to move to our next speaker in policy implications, Dr. Carol Medlin. She is an assistant professor of global health sciences at UCSF. She's also the associate director of policy evaluations at the Women's Global Health Imperative. Her area of research is the use of economic tools and incentives to promote public health prevention practices. She has served as a consultant to the Bill and Melinda Gates Foundation and the Global Fund to Fight AIDS, Tuberculosis, and Malaria. And she was a mentor of the What Works working group that co-authored the publication Millions Saved. Dr. Medlin, welcome.
Since you mentioned the What Works working group, I just wanted to point out, Ruth, where are you here? If anyone has any questions about the Millions Saved initiative, which has just been enormously successful, then Ruth is the person to talk to. She's the woman who made it all happen. So thanks to everyone here, and especially to the organizers. It's a real privilege to be part of the launch of a new global health initiative. I'm especially interested in Rice's approach to launching its global health initiative, taking advantage of its comparative advantages in engineering and the medical sciences and public policy. It's a similar kind of trajectory that we've been attempting to pursue at the University of California, San Francisco, although, of course, our focus is more exclusively on the clinical and medical sciences and not engineering. And unfortunately, we don't have the kind of glue that you may have here at Rice University that's provided by collaborating with the School of Public Policy in addition to other disciplines. So I'm very interested to see this approach, and I think it seems really promising, and I'll look forward to seeing how it works out. Over the past half century, as several of our speakers have already mentioned, we've had major and dramatic gains in health globally. There have been dramatic increases in average life expectancy and dramatic decreases in infant and child mortality. There's pretty strong consensus that these advances have been largely due to the discovery and diffusion of new technologies. And you would think that that alone would be justification for greater investments in the health sector. But in fact, research has really worked on being able to also show the importance of health to economic growth and development of countries in order to justify increased resources towards the sector. This has not always been the case. It's certainly becoming much more the case today. In economics, the health sector was traditionally viewed as a non-productive sector of the economy rather than one that did contribute substantial gains to growth and development. But this view has been changing, partly stimulated by the World Development Report in 1983 that began pointing to these types of gains, and then additional research that has occurred after that, pursued by many scholars, but Dean Jameson is one. You've already mentioned his name. Jeffrey Sachs is another who's really promoted this view. Okay, so what we've seen are rapid increases in spending on global health, especially over the past decade, and major new funders coming onto the scene, such as the Bill and Melinda Gates Foundation, the United States PEPFAR, the Global Fund to Fight AIDS, TB, and Malaria. Much of this due to the growing evidence about the impact and sort of the returns on investment in health, and also, as has been mentioned here, that it's just the right thing to do. Initially, and I would say just about a decade ago, the focus was almost entirely on securing more resources for the health sector. That was the big emphasis. And there was much less concern at the time when the need for new funding, when there became a growing awareness of the need for new funding, there was much less emphasis on what to do with the money once it became available. I like to think it's just helpful for me thinking about it in terms of we sort of assumed that there was a bit of the traditional R&D pipeline, which you can see up on the screen as our model for thinking about what would happen if we developed all of these new technologies. And somehow they would get developed and then they would just be automatically diffused. And what we've seen is that some of those assumptions have been maybe a little naive. The traditional pipeline, R&D pipeline, assumes a rather orderly trajectory of movement from product discovery and development, from basic science to applied research to clinical trials and to a final product. And of course, the pipeline expressed in this way says very little about the types of market incentives that underline this process, and that in fact had got us to the situation that we found ourselves in the early 1990s, where we realized that there was the 1090 research gap, where few of the research monies, about 10% of the research monies, were going to support research into diseases affecting over 90% of the world's population. So there was quite a lot of energy and effort put into addressing this 1090 gap, and thinking about how the traditional R&D pipeline just simply didn't express the kind of model we needed to think that through. This same kind of pipeline also says very little about what happens once a drug or vaccine or diagnostic technology becomes available. So once the product is made, then what systems are needed to assure access and delivery, what's needed to increase acceptability and uptake of the product. An expanded view of the pipeline might look a little bit like this, and I think would include aspects of what the U.S. National Institutes of Health are now referring to as the translational and policy agenda, looking at things such as how do you choose from available technologies, how do you decide what to scale up, how do you develop effective procurement and healthcare delivery systems, and then how do you ensure access and encourage uptake and acceptance of new technologies. So with growing awareness of the complexities involved in improving population health, there is less emphasis now, I would say, a decade out, on whether or not there is enough money available to do the job, and more emphasis now on the types of policy challenges that are involved in the development and the diffusion of new products. So I've tried to summarize some of these policy challenges by listing 3 very broad but comprehensive questions that I think reflect the state of our awareness today about what we need to do to tackle this challenge. The first question, as before and remains the same, are what policies are needed to support the discovery and development of new technologies, and specifically to benefit the poor and the disadvantaged. Secondly is, once we have new products available, how do we choose among them? How do we know what to scale up, especially in the absence of complete information about what will be effective in certain contexts? And thirdly, what is our strategy for how to scale up? This would be true both at the global, the national, even the local level. And like I said, these are very broad and sweeping challenges, but I think are sort of comprehensive of the type of discussions that are going on today. I don't want to spend a lot of time on the policy challenge number 1, which is how to support the R&D pipeline, because I think we'll have a lot more discussion about that this afternoon. But I think it is helpful to think about this challenge in terms of 3 disease categories, where you think about diseases in, this is creatively called Category 1, that are incident in both rich and poor countries, and so that there are R&D incentives for the private sector to invest, but products may not be immediately applicable to developing country settings. So there may be different strains and some modification of the product in terms of delivery requirements that are required, but by and large, the pipeline, the market mechanisms are functioning to sort of push things through the pipeline. A second category would be diseases that are incident in both rich and poor countries, but the majority of cases are in the poor countries rather than the rich countries. So R&D incentives may exist, but may not be commensurate with the actual global disease burden. And one way to think about this would be the example of malaria, where the northern countries have largely eliminated malaria as a major health challenge. And so the risk without the proper incentives and properly thinking through the process of developing interventions for malaria is that the drugs would be developed for the tourist market or for the military and not be so applicable for long-term use for people living in the poor countries where malaria is endemic. A third category is what I think of as the tropical diseases, where the disease is exclusively incident in poor countries, and research and development incentives are inadequate relative to the disease burden. And in fact, this is probably the area where the challenges to the pipeline are the greatest, because not only is the market size small, but the market is very poor. And so if you think of the different types of policy responses that are required to try to get things moving through the pipeline, if you think in terms of pull mechanisms and push mechanisms, which pull incentives refer to providing direct funding for research, which reduces upstream costs and risks of research and development. And pull incentives help create a more credible market downstream. As you move down these categories and into these tropical diseases, the pull mechanisms become more and more and more important. I think the point here is that it's not really possible to think in terms of a one-size-fits-all policy response to supporting the R&D pipeline. A much more analytical approach is required, and this is where public policy analysis comes in and why it's refreshing to see the kind of partnership that you're developing here at Rice University between the engineering and the public policy school. So what about public policy, policy challenge number 2, which involves the choice of how to pick from among all of the technologies available and deciding what to scale up and implement on a national or a global scale? We do have many important tools that help us in reviewing these kinds of choices and making these decisions. So these tools exist, for example, ways of calculating disease burden, drawing from evidence about efficacy from randomized controlled trials, and cost effectiveness assessments. But unfortunately, there's really no roadmap for how to turn efficacious interventions into successful large-scale programs. We're only just now beginning, or at least from my perspective, I think especially the science angle of things, is only just now beginning to address and understand the importance of context, contextual factors in helping to understand and choose among an appropriate mix of interventions. And I think there are also some real inefficiencies in about the way science is understood, perceived, and acted upon by policymakers that we need to consider. So what is so difficult about knowing what to scale up? I think especially among the technical and scientific communities who have not been well integrated into the policy and political process, we have some operating assumptions about a certain rationality to the process of policy and decision making, which unfortunately can be erroneous. An ideal process, this was published in the WHO bulletin last year, which shows that our basic assumption, or the way we wish things would work, is that we would move from basic science to single studies, evidence, and clinical trial information, to systematic reviews of the research and the evidence base, onto actionable messages that would then get picked up by policymakers and decision makers. And unfortunately, the process doesn't always work this way. Why doesn't it? Well, I think there's a number of reasons why it doesn't. And one is that I think it's very hard to get even scientific consensus, much less policy consensus, about what to do without a clear roadmap about what policies are needed to support the transformation of efficacious interventions into viable, large-scale, and effective programs. This is a slide from a WHO presentation which portrays the types of failures that can occur in rollout and implementation that can result as you can see, in a sharply reduced effectiveness of the intervention delivered through a large-scale program compared to what might have been expected by efficacy results from randomized control trials. Now, these numbers were actually made up, and so were these categories, but you can sort of see the basic point here, which is that you can quickly end up with a program that is much less effective than expected based on estimates of efficaciousness of the intervention or technology in question. Now, this slide is from a presentation by Willard Cates of Family Health International, and it's a quantification of the loss of efficacy of different HIV prevention tools resulting from differences in perfect use, which you might achieve in a clinical trial setting, and typical use, which might be more characteristic of a large-scale program. Now, these ranges that are provided, which are quite dramatic in many cases, are referring basically to adherence issues, so individual behaviors and related to uptake and acceptability of the technology. So you can just imagine if you were to move backwards into these types of issues, which deal a lot with delivery systems and programmatic issues, the kinds of range, how the range would expand. Okay, on a second point about the difficulty of knowing what to scale up, this is really from my observations of being a policy researcher at a medical school at UCSF. And what I'm aware of in watching the scientists work and go about their research in global health is that science and technology is only just now beginning to make some of the contextual criteria explicit for understanding about what will make an intervention effective when it's rolled out in particular contexts. So this is a slide from a presentation given by Judith Wallerstein of University of Washington, which basically is trying to describe the importance of taking epidemiological context into account and determining which interventions and technologies should be rolled out as part of a comprehensive AIDS prevention strategy. In this case, both the targeting of an intervention and the specific clinical strategy, such as whether or not to screen for sexually transmitted diseases as part of a broader HIV/AIDS prevention strategy, these things vary depending on whether or not you're dealing with a concentrated or generalized epidemic and whether or not you have high or low transmission rates. Now, some of this information, as I was pointing out, is just not immediately obvious always from clinical trial results. Sometimes it is, sometimes it isn't. And I think the positive sign is that we're beginning to make these kinds of contextual issues much more explicit. I think for policy and decision makers, though, it's really important to note that other contextual factors, such as political and economic or social and cultural contextual factors, may be equally important. Maybe not as important in the scientific way, the kind of result you might get from an epidemiological study, but nonetheless very important. And a case I would cite from my own group is that my group spent, I was not involved with this project, I have to state a disclaimer, but my group spent a long time developing a microcredit intervention, which is creating businesses for young women at risk in Zimbabwe. Spent a long, long time trying to develop that intervention, only to discover that Zimbabwe's economic growth meant that there was really no employment, no market outlets for the type of intervention that they were promoting among these young women. So they could have had the most effective program in the world, but it simply wasn't the right political and economic context to make that intervention work. I think another really interesting point that we have today with the new evidence that has come out around male circumcision and the huge impact that it can have on reduced transmission is really a question of sort of what is the right context for rolling it out. So we have the efficacy trials. We know how effective it is, but do we know how to roll it out? Do we know what the appropriate contexts are for rolling this intervention out and how to do it? Now, I think even if the science and technical issues involved in choosing what to scale up could be easily sorted out, which, as I've pointed out They cannot be quite so easily sorted out. But even if they could, I think it's likely that we would still see some inefficiencies in the policy uptake of scientific findings related to global health. We seem to lack at the global level effective decision-making mechanisms. And I think one illustration of this, and it's a risky one to point out because I'm not trying to get into a technical point here, I'm trying to use this to illustrate a point about policy process, is the decision that was made to transition African countries to the use of artemisinin combination therapies for malaria. Now the scientific base for, those are called ACTs, the scientific evidence base was largely based on trials in Asia, and debate about their relevance for Africa was still ongoing even up until about 5 years ago, 3 or 5 years ago. There was ongoing research, including from UCSF investigators in Uganda, that cheaper and non-artemisinin-based combination therapies remained effective, despite the fact that chloroquine and other types of monotherapies had now become ineffective due to the increase in resistance. However, in around, 2003, 2004, the international agencies, WHO and the Global Fund in particular, found themselves under attack for not pushing hard enough to assist African countries in changing their drug policies. And this is just one example of the type of public pressure that was placed on the international agencies, accusing them of medical malpractice for not agreeing to switch to ACTs more rapidly and allowing countries to continue to have a drug policy based on chloroquine and other now ineffective therapies. And the argument was that this was medical malpractice for not being more in the forefront of a shift in policies. What happened, however, was not just a debate around what to switch to. The impulse was to leapfrog directly to ACTs. Now, ACTs are very effective, and I don't think anyone would argue that it's actually a mistake. It may be, though, that we lost an opportunity to continue using other cheaper, cost-effective combination therapies that were not ACT-based, simply because the public pressure was so intense that the action had to occur, and the large organizations really felt as if they needed to respond to this type of critique. And again, I really want to emphasize that I'm not trying to make a technical or scientific point about the wisdom of switching to ACTs. I simply want to say that our policy process for reviewing this issue was somewhat lacking, and I think demonstrates that our global health policy and decision-making processes are highly vulnerable to this type of public pressure, which may not be as well guided by scientific evidence and technical opinion as it should be. And in this case, it may have resulted in a rush to judgment that may actually prove costly to ministries of health over the short to medium term. So finally, policy challenge number 3, I think, refers to how to scale up. So once the decision has been made regarding what to scale up, then, okay, now that we know what we want to do, how do we do it? Obviously, the specific challenges can depend on whether your focus is global, national, or local. However, I wanted to briefly mention 3 issues that I think are broadly applicable, whichever level of scale-up you're dealing with, having to do with, first, different capacity requirements for scaling up, depending on the type of intervention in question. Secondly, the importance of fidelity, what's called fidelity, in transferring interventions from one setting to another. What are the core components? What makes for making an intervention effective? And thirdly, that different factors are relevant at different phases of implementation and scale-up. And I think all of these issues really demand a more rigorous policy assessment and evaluation prior to leaping in and saying, okay, let's just scale up. So the first point is that different types of interventions have different capacity requirements and place different demands on, say, the healthcare delivery system, healthcare professionals in particular, and government regulatory capacity. This is just one way to think about it. There's many different ways to consider these types of capacity requirements. One would be to distinguish between whether or not you're dealing with a substantially product-intensive intervention versus a service-intensive intervention, or a predominantly behavioral change-focused intervention. And the distinction has to do with the type of capacity that's required to deliver these interventions. So with product-intensive interventions involving a simple transfer of a standardized technology, it may not be simple. Your vaccination campaigns are incredibly complicated logistically. However, the product itself does not need to be tailored to the individual patient and is not dependent on certain behavioral change responses by the individual, although, as we've seen in the case of polio, certainly acceptability comes into issue. So the types of modalities that we think of with product-intensive interventions are things like the mobile vaccination teams or those administering mass drug administration. Service-intensive interventions, by this I actually mean it doesn't necessarily need to be clinic-based, but often is. It could be home or school-based, but the intervention is not easily standardized and may require some kind of ongoing monitoring of the patient's condition or status. So primary health care falls into here, even anything from simple surgical procedures to complex surgical procedures fall in here. And again, our modality has to be different. You can't necessarily send out mobile teams, although with some simple surgical procedures that has been true, such as cataract surgery. But by and large, it's a far more complex or requires a higher skill level of the professional staff that's delivering the intervention than what might be required of a product-intensive intervention. And finally, with behavioral change interventions, which require the active participation of the individual and cannot be received passively in the form of a vaccine or a supplement, these require, again, a different type of delivery modality that's very dependent on sort of reinforcing behavioral changes, creating trust and confidence with the individuals that are targeted. And I think a very good example is ORT in Bangladesh, where it was really the mothers who, once they became convinced that they had a tool that they could use to treat their children, then this became a very widespread intervention, a very successful one, led by health teams going out, educating the mothers who were then educating others. So I think a second issue that's pertinent to the discussion about how to scale up is one of fidelity and the ability to transfer an intervention from one setting to another. This is also, I think, related to this issue of how our evidence base is constructed around randomized controlled trials, which is extremely good for some things, and sometimes makes it difficult for us to know then what to do with that information once we have it. So some investigators have taken the concept of fidelity to mean that all components of the intervention must be the same, equally applied in all different sites, basically prescribing that the adopters of an intervention that has been proven efficacious in a randomized controlled trial remain faithful to the formula that's been tested and proven in the original setting. However, this type of fidelity is often not possible from a programmatic or policy standpoint, and may confuse, in my mind, the core elements of the intervention with the kinds of supportive or programmatic trappings that are required to deliver it. So in this example, which is a very basic example published in the BMJ, actually what year? I think it was last year. The programmatic components of the delivery strategy could be either adopted wholesale or flexibly adapted to achieve hopefully the same result as that obtained in the RCT. And there the challenge is to really figure out what's the causal mechanism that's driving the effectiveness of that intervention, and being sure to replicate that, being faithful, having fidelity towards that causal mechanism in scaling up from a randomized controlled trial to a program context. This final slide is an example of a framework for scaling up cost-effective interventions. It's one that I'm doing with an AIDS prevention scholar at UCSF. to think about scaling up behavioral interventions for AIDS. And I'm using it simply to illustrate the importance of the different phases or stages of implementation in moving from a project to an effective large-scale program in determining whether or not that program is going to be successful. So you can see here, well, maybe you can see here, that as you move from left to right, there's a distinction between the different phases that must be taken into consideration, where at each stage there are different policy challenges that need to be addressed in making sure that you are scaling up into an effective program. So you've got pre-implementation stage over to the far left, which is highlighting the importance of understanding the micro and the macro context before you are actually choosing the intervention that you want to use. And then once you have chosen that intervention, you are focusing on implementation and rollout, but there's still within that stage different, basically different challenges you need to meet, which have to do with retooling the intervention to adapt to the context that you want to deliver it in, integrating with the existing delivery systems and the healthcare system, and then rollout and delivery, which may have quality requirements that are both specific to the intervention itself and specific to the program itself. And then, of course, the importance of evaluating and understanding your impact in terms of a variety of different types of outcomes. So this has been somewhat of a sweeping overview of some of the policy challenges related to the development of new health technologies for the developing world. And I would just point to three very brief conclusions, maybe confusions too, but conclusions, to point out that the discovery, development, and delivery or diffusion of new technologies is crucial. We know this for a fact, crucial for improving global public health. However, the process is not a simple process. It involves complex and often context-dependent policy responses. We need to be aware of those. And I think this is where the cross-disciplinary approaches come in. Because these processes are so complex, the cross-disciplinary approaches are needed to help inform and develop an effective policy response to these new technologies. So I wanted to thank everybody very much. It's wonderful to be here, and I also wanted to thank a couple of the people who were helping me pull together these slides. Thanks.